In this section, we'll discuss prevalence and research. It's important to know what we're talking about, how many people have a problem, and the research that exists. Unfortunately, we don't have a lot of research in relation to the deaf and hard of hearing population, but we'll share with you the information that we do know. Before we begin with the research that is out there, it's important to define terms. The concept of substance abuse in this presentation will be defined as a chronic disease with continued use despite harmful consequences. There can be a genetic factor. Psychosocial and environmental factors can also have a play. The use can be progressive and potentially fatal. And when a person uses drugs or alcohol, it can change the way they feel, think, and behave. Some people might be able to drink and know their limits and stop, while others are unable to do so. Some report the first time they took a drink, they loved it, and from that point on, they had a problem. And others can drink and not have a problem until much later. It really is dependent on the person. What happens with one person and their experience will not necessarily be the same for another person. For example, I might be able to take a drink and not have a problem as compared to a person who takes one drink and becomes addicted. It's important to remember that when problems arise with family, friends, and work, if the person drops all of those things just to be able to drink, that's an indication of an addiction. Within the hearing population, or the general population, there are about 8% of 12 and older who use illegal drugs. Illegal drugs include marijuana, cocaine, heroin, and we know that based on the Minnesota Chemical Dependency Program, we've treated over 1,200 people. And of those people, they report their preference is marijuana or alcohol. Also, within that group of deaf individuals, they report that they started using at the age of 10. However, right now there are no treatment programs that service individuals under the age of 18. Most people at the Minnesota Treatment Center don't arrive until they're 25. That doesn't mean that a person didn't have a problem until they were 25. It's just that that person didn't receive help until they were 25. Remember, 8% have admitted to using illegal drugs over the age of 12. Let's say there are 2 million people who are deaf and hard of hearing. And we know within the hearing community, the statistic is 1 in 10 typically have a problem with drugs or alcohol. We would estimate that if there are 2 million people who are deaf, that there should be about 4,000 people who need to be in treatment if we base it on the number 1 in 10. And we don't see that number of deaf and hard of hearing individuals on a daily basis in treatment. It's just not happening. One of the problems is that there's no documented research of how many people actually have a problem with substance abuse within the deaf and hard of hearing community. We're estimating that data, which is not really representative because we're using small restrictive samples. There are a lack of appropriate treatment options designed to meet the needs of deaf and hard of hearing individuals. It's hard to get the information necessary. Many people who are trying to research options aren't going to doctors' offices. Frequently they're living on the streets and homeless, and it's hard for them to get the information they need. There really is a problem within the deaf community in relation to substance abuse, and we suggest it's probably even more serious than that of the hearing community for a variety of different reasons. In 1994, many years ago, one researcher tried to figure out, based on the general population of hearing individuals, how many people had a problem and what kind of drug they typically used. Then we generalized these estimates to the deaf population. The highest number was deaf individuals who used marijuana. Remember, this is not exact science, these are estimates. There are 3 treatment population studies. One is from recent. 2 involve hard of hearing and 1 involved deaf. The one I researched was post-treatment improvement and abstinence associated with attendance at recovery meetings. We researched 100 people who went to treatment and asked about school, employment, family support, asked about their schooling, if it was a deaf or hearing school, and we found 3 things that we focused on for our study. The 3 things that helped a person remain sober were going to recovery meetings, such as a 12-step meeting. And remember, they don't have many options, but it does help in their recovery. Second, their family is able to talk to them about their problems, which helps a lot. But unfortunately, many deaf individuals don't have people who can communicate with them within their family. And the third was employment. We know that more than half of the people who went to the Minnesota treatment program are on SSI and are not employed. But of those who were employed and were involved in this study, they tended to be sober longer than those who were not employed. A person who has private insurance would be lucky to get maybe 3 or 4 days at an inpatient treatment center. As compared to a person who uses SSI, they could have more days covered to stay in an inpatient treatment program. So it's interesting that whether a person works or not, or whether they're employed or not, affects their sobriety. A research study done on hard of hearing individuals found that clients with a hearing loss reported equal or a little more progress in treatment as compared to the hearing clients. But that was specifically a hard of hearing group study. A recent study also looked at hard of hearing, but it looked at the youth population, and it used a screening tool called the GAIN. When a person went to treatment and said they had a hearing loss, and they showed up at treatment, it seemed that they had more severe issues than the hearing counterparts. It's very interesting because many people who need help and show up for treatment programs tend to have co-occurring disabilities. The statistic is about 30 to 60% within the hearing community have additional mental health diagnoses. Within the Minnesota Chemical Dependency Program, about 70% of those who show up also have a co-occurring disability with mental illness. So it's important that clients or students that you work with, that you recognize that they might have additional disabilities. They might not just be deaf or have substance abuse issue. There may be other factors involved. And sometimes the substance abuse issue might cover up the mental health issue. And so if I stop using, my mental health issue might show up. And we would say up to 90% of people who abuse drugs have a co-occurring disability and need treatment. This becomes very complicated. In the general population, and also within the deaf community, we find many similarities. If I begin using drugs or alcohol at an early age, there's high risk of addiction as I become older. There's a higher risk of physical and sexual abuse. Family history and genetics play a huge role. Multiple psychiatric conditions, peers and friends who use, and the family environment. If there's conflict or too many limits, it can also cause high risk later for addiction. Within the deaf and hard of hearing community, We know that 90% of deaf individuals are born to hearing families. That in and of itself can present an additional high risk. Because of lack of communication, problems that can occur at home, there can be an additional risk. Also, if a student goes to a mainstream setting for the deaf, typically there are no prevention education programs. The hearing kids tend to have that program and learn this information, but deaf students do not. Therefore, they don't understand a lot of the issues or problems that are associated with use. They want to be just like their peers, and so for that reason, often students begin to use. Some research shows related to drug dealers that they target deaf kids specifically because they know that they won't get arrested because police don't like to get involved. And there's also additional peer pressure, so deaf kids typically use more than hearing kids. And because there's a lack of support within the deaf community, they're afraid to have that negative image. So there's a lack of knowledge, a lack of materials, a lack of training, and a lack of education. And the deaf community doesn't help in this, and so this adds a higher risk. Finally, it's important to remember that for additional funding, we need more research. Because we don't have enough research at this point, it's tough for us to get more funding to provide more services. So if you have the opportunity to get involved providing services and research, it'd be important to do so. Thank you.